Okay, Pete, I just want to actually quickly introduce you to everyone. So it's really a big privilege to have you to speak to us today. Your bio is quite short and this informs us that you study medicine and you specialize, but there's actually so much more to you. I think if we Google your name, you get numerous journals, articles where you're involved. You're definitely a legend in hematology for the last 30 years. Your passion for coagulation hematology is really inspiring. You're definitely one of the doctors that motivated me to specialize in hematology. So it's really a big privilege today to present to you and have the honor for you to talk to us regarding peri-operative anticoagulation management. So I'm looking forward to enjoy the presentation, Pete. Thank you.
It's only a pleasure, but I'm sorry that I convinced you to do hematology, but I still think it's the best. Anyway, so the topic is really peri-operative anticoagulation management. And if you think about the topic, it really involves more than just what it seems if you just read it. It's really about anticoagulation that starts in theater, in other words, intraoperative period. And then the big thing, especially with the orthopods that wants to give an aspirin post-knee and hip surgery. And then also post-operative period. But we're not going to talk about that. This is only about the patient that before surgery already is on either an anticoagulant, and that's the first group, that's unfractionated heparin, lone white heparin, Arixtra or Fondaparinux, warfarin, the VKAs, vitamin K antagonists, the DOACs, the direct oral anticoagulants, and those are the anti-2s and the anti-10s. The anti-10s we know is rivaroxaban and apixaban, and also the anti-11 drugs, which slowly is making their way into the market. Not always successful, but it's definitely something that we will have to deal with in future. And then, because they've got very long half-lives. And then the main thing to also realize is that there's a huge difference sorry, between an anticoagulant, and a lot of people think of anticoagulation including antiplatelet drugs, but there is a big difference and they should be treated differently. And I'll show you. So the antiplatelet drugs are things like aspirin or dispirin, dipridamole, Plavix or clopidogrel, prasugrel or Brilinta, ticagrelor, and then cangrelor, which is really not in our country, which is a pity. And cangrelor is a short-acting P212Y2 P212Y12 antiplatelet drug, and it works very well for a short period, and that's what they use to bridge antiplatelet drugs, but it's not available in South Africa. And then lastly, one should just remember that patients may have something that influence, and it's really peri-operative anticoagulation if they take other drugs. For example, there's a recent article on NSAIDs. A patient on an NSAID will influence your platelet function, and other things that one should remember. The 3Gs, ginkgo biloba, ginseng. We'll talk about that. So bottom line is this: we're only going to talk about having a drug on board that will influence your coagulation system. Now, there are various articles, many. I'll show you some of them. Very many of these drugs. I sound like Trump now, but there are lots of these articles. Now, the most extensive of all of them is the peri-operative management of antithrombotic therapy, which was written by Spiropoulos and Ketis, these two guys. They're important guys. Spiropoulos has been in South Africa, interesting guy. Anything that these two guys write, you can really, or put their name to, you can read. And Mark Samama, his dad was also a well-known guy in France. So this is really, it's in the ACCP guidelines. It's for free, you can download it. But it's extensive, and it's really something to read. It takes you a long time. I think what also is available is the New South Wales guidelines. Now, the Australians have been really good in hematology. If you look at all their approaches in hematology, their practical approaches. So the bottom one is really the most extensive labor-intensive reading, whereas the top one is much shorter and very clear and easy to read. And I'll show you some parts of it. So if you approach a patient that is on anticoagulation and you're going to take this patient to theatre, you need to try and balance the risk of thrombosis and the risk of bleeding. So the risk of thrombosis here in dark blue, and these risk factors may be in the patient or due to surgery. If you remove a toenail on a patient, it's a huge difference from doing a hip replacement in a patient. So the type of surgery plays a role. And then on the other hand, a patient with a recent deep vein thrombosis going to theatre is at a high risk of thrombosis. So you need to consider the patient risk factors and the surgical type of risk factors and the length of surgery, etc. We all know that. And on the other hand, you need to look at the bleeding risk in a patient. Now, the patient bleeding risk is something that everybody wants to do a blood test for, and I'll show you that that's not a good idea. You can do blood tests, but you first need to examine the patient. So the bleeding risks in a patient, and then at the same time, the bleeding risk due to surgery. Again, if you remove a toenail on a patient, the risk is minimal. But if you do a hip replacement, the bleeding risk is these days less, but it's still a major bleeding risk. So that's the issue. You need to try and balance, and this is what it's all about. You need to have this patient for a period free of bleeding and free of clotting. And that's not always easy, and I'll show you what we do. So if you then look at these risk factors, let's just quickly look at the ones that I sort of blanked out. The thrombotic risk of surgery. Thrombotic risk of surgery is something that we need to think of post-op. And the patient bleeding risk is something that is already present in a patient because this patient is already on an anticoagulant. So it's not in a normal patient, you would look at thrombotic risk and patient bleeding risk, thrombotic risk of surgery and patient bleeding risk. But in this instance, the patient is already on an anticoagulant, so the bleeding risk is there. And the main issue is this period intraoperatively. Post-operatively, any patient will probably need some form of anticoagulation. And these patients may need higher doses, etc. We'll have a look at that. But that's so the two really major areas to look at is the patient's thrombotic risk and the surgery type of bleeding risk. That's to keep in mind. Okay, so let's have a look quickly at those. The patient thrombotic risk. This means, what is the risk of a patient going to theatre if we stop his anticoagulation to form a clot again? To realize what the risk is, we need really to know why the patient is on anticoagulation. Now, there are three reasons why patients are on anticoagulation. Either they've got atrial fibrillation, or they had a deep vein thrombosis or a pulmonary embolism. And I'll show you now. Or they have a valve replacement. But those are the major three reasons. There are many other minor things that people may have beyond anticoagulation, but I think those are the three important ones. And then we also need to think how big is the risk intraoperative and perioperatively in these patients. So patient's thrombotic risk, how do we approach it? We've got three categories. We've got a high and a moderate and a low category on the left-hand side. And then we have those three entities that I said that a patient would be have underlying to have been put on an anticoagulant. If we combine those and we look, for example, let's look at on the right-hand side, on venous thrombosis. Now, there are patients that has, if you look at the risk category on the left-hand, I don't know if this works. If you look on the left-hand side, you'll see in these patients, the risk per month of deep vein thrombosis or recurrence of a deep vein thrombosis is more than 10%. So these are high-risk patients. 1 in 10 of them will develop another clot. And the conditions that will cause that are these conditions. It's either a recent VTE. Now we know as soon as you get a deep vein thrombosis, you activate the process of extension or propagation of a clot is a major event in deep vein thrombosis. And that's why we know about it. Intraoperatively, most patients will develop small clots. It's just a normal event. And we break those clots down. You will not get a patient out of theatre if he couldn't develop a clot, because he will be still bleeding and you will still be standing in theatre. So you need clot formation, but we know that as soon as a clot is formed, that propagation happens. And that's what we want to prevent intraoperatively. So we don't give anticoagulation post-operatively to prevent any clot formation. We want to prevent clot propagation. And we know that intraoperatively, patients will form small clots in the calf, the cusps of the calf veins, and these will disappear. Many patients will form those. 75% of patients will form small clots because they lie dead, still stasis. They're hypercoagulable because of the theatre environment, etc. So bottom line is this: we know that a deep vein thrombosis tend to propagate, and that propagation is highly active in the first 3 weeks post deep vein thrombosis. And you will see that the treatment of deep vein thrombosis with any of the drugs starts off with a higher dose. If you use apixaban, you will start off with a 10 milligram BD for 5 days or 7 days, and then you go down to a lower dose. If you start with rivaroxaban, you start off with 15 milligram BD, and then you go to 20 milligram. So all of these conditions, at first 3 weeks post deep vein thrombosis is a very high risk. So what we know is that the more recent a patient has had a deep vein thrombosis, the higher the risk of taking that patient back to theatre. It's important to remember, if surgeons want to do a re-look in a patient, we need to tell them that, be careful, the risk is very high. But you need to get the patient to form a clot. That's unfortunately. And then other conditions with deep vein thrombosis, if there's a severe thrombophilia, you need to be careful. Those patients need to be very carefully looked at. They've got a very high risk. Antiphospholipid syndrome that I've spoken on before, which is a very high risk of thrombosis. If a patient has a vena cava filter, now the thing with the vena cava filter, it prevents pulmonary embolisms, but it actually increases the risk of deep vein thrombosis below. So that's also another one to think of. And then if there's active cancer, these patients got a very high risk of thrombosis. If these conditions are present, we know that they have a very high risk of recurrence, and you will breach these patients. They will be, you will have to bridging will mean that you will take the drug that the patient is on and see if you cannot change it to another drug that is shorter acting. In other words, you want to keep the period that a patient can be operated on as short as possible. So if we look at warfarin, for example, we know that warfarin works for 7 days, 5 to 7 days. If you then stop the warfarin, the iron R will slowly recover, the patient will become more hypercoagulable again. So to stop warfarin effectively prior to surgery, you need to stop it 5 to 7 days before surgery, depending on what dose the patient is on. But so that's what bridging means, is we then, instead of the warfarin, use a low-grade weight heparin, which we can stop for only 24 hours. And that's why we bridge them. So these patients need to be bridged much more than these patients. A patient with a deep vein thrombosis that was more than a year ago, and there was good reason for this. So it's not a unprovoked or a spontaneous thrombosis. Those patients got a very low risk. We don't need to bridge them. And then we have this in-between group, a patient with a recurrent VTE, also a high risk, non-severe thrombophilia. In other words, heterozygous factor 5 or heterozygous prothrombin mutation, 3 to 12 months. So there is a period that's more orange, that we will say maybe we should bridge, maybe we shouldn't bridge. But in these cases, I think I would still bridge. So that's venous thrombosis. We need to have an understanding of what is the risk of recurrence. Then if we look at atrial fibrillation, the old Chatsworth score, the other newer, much nicer scores like the Garfield score. But the Chatsworth score, if the Chatsworth score is high, we know that the patient is at high risk of stroke. That's why we start, if a CHATS-VAS score is 0, you won't start anticoagulation in AF. You may, but you don't need to. So atrial fibrillation with rheumatic valvular heart disease or a recent stroke or a high CHATS-VAS score, those patients, you can't just take the thing. You can't say to the patient, we're going to stop your warfarin and we take you to theatre and you'll be okay. It's not true. On the other hand, mechanical valves, I think all mechanical valves we need to. You can see some of them, we know that the risk is lower, but it's always difficult in these patients to decide. I think mechanical valves needs to be read. They should be, maybe the newer ones, but one should be careful in taking those patients. So bottom line is this, you need to be able to define the thrombotic risk according to why the patient is taking an anticoagulation. Second one is bleeding risk. As I said, this is not really important for this purpose because these patients already has a high bleeding risk because of being on anticoagulant. But I just want to quickly show you, we all want to be able to, we live in a world, and that's why we doctors, we want to be sure of everything, and we can't be sure of everything. You can't do a blood test to say this patient is going to bleed intraoperatively or not. You can try and define it, but to see a patient and decide, I'm just going to do a battery of tests to decide whether he's going to bleed in theatre is wrong. And this article just confirms that. They looked at Rotem's TEGs, sonoclots, different viscoelastography, platelet functions, the normal blood tests, the influence of anticoagulants, etc. And the bottom line is this, what they found is that patients, a blood test is not a good idea. A much better idea is to ask the patient a question. Ask him a few questions. And the questions are, the first question, is it true? In other words, a patient, you should ask at least a patient, do you bleed easily? Do you bruise easily? Did you, when you had your teeth extracted, or circumcision, a little Jewish boy, whatever, do you bleed easily? And that should be a red flag. The second thing is there anybody in your family that bleed easily? The third one is, do you have nosebleeds or do you bleed in your joints? And we know that primary type of bleeding is a nasal bleed or petechiae. That's a platelet dysfunction or from Willebrand disease. Or is it a clotting factor? And then anybody with a liver, renal, or hematological disorder, remember they've got defective coagulation. Any drugs on board? Not which drugs are really? Not any drugs. Do you have any drugs? People don't think that taking a lot of garlic or garlic drugs, garlic tablets or pills that they take from the pharmacy is a drug. And then what happened at previous surgery. But this is not important now. I just wanted to show you. And there again, you can see the Australian health care providers, how they approach it. You can see they look at bleeding history. It's an important part of managing a patient peri-operatively. So the first one was, we need to know why is the patient on anticoagulation, and we need to know that specific reason. How big is the risk to stop anticoagulation in that patient? What is the thrombotic risk in that patient? The second one we just spoke on now is the bleeding risk. We know it's not that important in the patient already on anticoagulation because he's already high risk, but at least one should know about it. The third one, the type of surgery. Now, I think that's not only the type of surgery, it's also the type of surgeon. So different people, the longer, the various factors that can happen in surgery. A very cold theater. Some of the surgeons want the theater to be really very cold, and you walk in there if you do a bone marrow or you have to do something in theater. And that decreases your platelet function, for example. Causing anemia in a patient. If a patient starts bleeding, as soon as the HP drops to 8, the platelets are not pushed against the vessel wall, and the patient will start bleeding more. There are different things that are happening, just temperature, etc. And the other interesting thing is, as soon as your temperature drops, or the patient becomes acidotic, your pH changes. That influences platelet function as well. But it's an interesting phenomenon. If your temperature drops dramatically, the platelets pool in the spleen. They hide in there. So having a very cold theatre is not always a good idea. So that's all the things you can do. Intraoperatively, what about the type of surgery? Are there different types of surgeries that's linked to bleeding? And it's not only the surgeon and the sister and etc. It's really the type of surgery. So dental procedures, we know removing one tooth has got a minor risk of bleeding. It's not to say that one should keep an INR of 3.5 and pull a tooth out, but with an INR of 1.8 or 2, surely you can remove a tooth and use some local cyclocapron in that cavity and you'll stop the bleeding. So we've seen patients on warfarin for valve replacement that goes to the dentist, and the dentist will tell them, you know what, we're going to remove one of your teeth. You must stop your warfarin. And then that patient's got a mitral valve, metal mitral valve, and the risk is huge. And then they start again. In that first period, they're also very hypercoagulable. So one should just be careful of that. So you can see which procedures has got a low risk of bleeding. This cataract procedure, remember, that's an avascular area where they work. But just remember that often these guys don't get an anesthetic because they don't want to wake a patient, and because if you wake a patient, the intraocular pressure increases, so they use a local injection behind the eye. That pushes this into a different category than a minimal bleeding if they use retrobulbar anesthetic. And you can see external fixators, good heavens, that's a nothing. You can see these patients can really be operated on whilst on anticoagulation. The second group is the low to moderate group, and these patients, I think you can have some of the anticoagulant on board, and depending on the skill of the surgeon, etc. But also be very careful with colonoscopy, because if they do a large biopsy, this patient can really bleed a lot. But mostly these are things that you can see and you can fix immediately. And then the high risk is everything else. I think most patients going to theatre falls into this group. And for this group, you need to have a 4 to 5 drug half-lives interruption. And so you need to know that there's nothing on board almost. And then the last one is the thrombotic risk of surgery. And we know that these patients do have a thrombotic risk after surgery because that's why they're on an anticoagulant. So for the patient that's not on an anticoagulant, we can use the Caprini score, which is a fantastic score, I think. And Caprini score has even been shown to work very well in orthopedic surgery. So even orthopod wants to decide whether he uses aspirin or low-grade white heparin, or I'm not a keen fan of warfarin, but or a DOAC post hip and knee replacement. If you just do this Caprini score, it will tell you that you can't, for example, use aspirin in certain patients, and you should use something stronger, because aspirin does have an anticoagulant effect, but it's about a third of any of the others. So if you have a patient with a high Caprini score, you're playing around with aspirin, you will find thrombosis. But that's, again, not for this talk. That's just something to think. It's like the patient's bleeding risk. So the thrombotic risk post-surgery, we know the patient has a thrombotic risk. So the steps would then be, to make it much easier, we look at what type of surgery the patient is going to get. Is it a high or intermediate risk, or is it a very low risk? Is it intraoperative? Is it brain surgery or intraoperative surgery where you cannot have bleeding versus a tooth extraction where you can manage? And then you decide whether you need to interrupt or not. If it's low, you don't need to interrupt. You can maybe lower the dose or skip one dose. And then if you decide, yes, I'm going to interrupt, you need to know what is a thrombotic risk, and then you decide whether you're going to bridge or not. Let me show you what I mean. So patient, this is an example, again from the Australian group, it's so easy. Patient taking warfarin and getting elective procedure. So you look at the surgery type. Is this a low or intermediate high group? The low group on the left, So it's minimal bleed. It's going to the dentist. It's not removing 10 teeth. It's removing one tooth. And in these patients, the risk is low. And you just make sure that the INR is not above 3 or above 2.5. You keep it about 2.2, and the patient can then proceed to surgery. On the other hand, if the procedure is intermediate or high, we immediately need to know, to decide we're going to interrupt because the risk is high. Now we need to know how high is the risk intraoperatively for this patient to form a clot. In other words, if this patient is going for major surgery and he had a deep vein thrombosis a year ago, and it was really due to well-known factors that are now absent, you're not going to breach this patient. He doesn't need anticoagulation. You can start post-op with anticoagulation. And then in that patient doesn't need bridging. But a patient with a valve replacement going for surgery, that's a high risk. You know that you're going to interrupt it. You know that the thrombotic risk is high. You're going to breach that patient. So it's so easy. And this is the way that we breach these patients. The minimal bleed risk patients, we're not going to stop the warfarin. The dentist can just make sure that the INR is lowish. The patient can stop the night before with warfarin, depending on the dose that the patient that takes 10 milligrams daily and you stop will have a quick drop in the INR, whereas a patient takes 2.5 milligrams of warfarin every third day and you stop for a night, they won't even know that they stopped. Their INR may be 3.5 going to the dentist if you stop for one day. So you just need to at least look at a patient and consider what you're dealing with. And then the low to moderate risk group, you would stop the warfarin 5 days beforehand. You would put them on a low chloride heparin. Now, this dose of the low chloride heparin also depends on the risk of thrombosis. For example, if you're a high-risk patient, a patient with antiphospholipid syndrome, that you stop the warfarin, or a patient with atrial fibrillation that's got a high CHAS-VAS score, or a patient with underlying malignancy and a deep vein thrombosis, or a patient with a valve replacement, this low chloride heparin here needs to be in a therapeutic range. In other words, you need to give it BD. A patient with a low a previous deep vein thrombosis, you can maybe use a once a day dose. This also, but most of these patients, because they're high risk of clotting, your decision is already made there that you need to breach them. You need to give a BD dose. And remember one thing, if you give a BD dose to a patient, you need to stop 24 hours prior to surgery. You can't give it up to 12 hours. So a low chloride heparin, once a day, you can stop 12 hours prior to surgery. But low chloride heparin twice a day needs to be stopped 24 hours prior to surgery. And then you will resume day one, depending on the underlying condition. You will see here that the Getters and Spiropolis and ACP say that you can start the warfarin. There is a tendency to start it. I'm a little bit hesitant starting warfarin just immediately post-surgery. It's been shown to work, but it does cause an initial hypercoagulable state. Maybe it will help the patient not to bleed post-surgery, but I would be a little bit worried. So I would rather continue with the low chloride heparin. So this is really, in a practical sense, what you would do. If a patient doesn't need bridging, in other words, the tooth extraction, not a tooth extraction, if a patient needs to stop, but doesn't need bridging, in other words, a deep vein thrombosis many years ago. A patient had a deep vein thrombosis 2 years ago, he's still on warfarin, but he doesn't need to be on warfarin anymore. You just stop enough days beforehand, check the INR, make sure that it's absent, and you continue. But if you need to bridge, you can bridge with a low chloride heparin. As soon as you can start the day after stopping the warfarin, or you can wait a day because the warfarin effect will still be there. Doesn't really make it. A patient won't bleed because he's on warfarin and enoxaparin. A patient will clot if he's not on any of the two. And then you check your iron on, you can do your surgery, you stop your lymph node wide heparin 24 hours, as I said. Now, the advantage of using unfractionated heparin with all the problems around it is that you can stop it for a shorter period. You can stop the infusion 4 to 6 hours prior to the procedure. So if you have a very high risk patient, you can put him rather on an unfractionated heparin and take him to theatre for 60 hours. Here's the patient here with a lymph node wide heparin would be 24 hours without anticoagulation. So if you want to shorten that period even higher, you're going to use unfractionated heparin, and you can stop for 6 hours. The problem with unfractionated heparin is things like heat, low platelet counts, post unfractionated heparin, etc. But it's doable. So the DOACs make it so much easier. The DOACs, you can give this picture to an orthopath and he can read it like an X-ray. You can just read this side which drug you're on, and just remember the bigatran is so highly renally excreted, so you need to know what the renal function of a patient is. And then you again decide what is the surgical risk. Is it a high or medium risk, or is the low risk? That moderate, in my opinion, should be there. But you look at the risk of bleeding, and then you decide how long before surgery you're going to stop. So if a patient is on apixaban and there's a high risk of bleeding, you're going to stop 2 days prior to surgery. You can do a level here, but you don't need to. The big thing to remember here is that in this period, do not add a lymph node wide heparin. We do not breach DOACs. DOACs does not need, none of the DOACs needs to be breached. And look at the bigatran. A high risk of bleeding with the bigatran with decreased renal function, you need to stop 4 days prior to surgery. And in this period, don't think, oh, you know what, I'm going to have a clot or whatever in this patient. He's going to have a stroke, he's got atrial fibrillation. Then make another plan, but don't use a lymph node wide heparin top up, because that top up that you give this patient cause bleeding. It's been shown to cause bleeding here. And here's the period. If the bleeding risk is high, you wait a day and then you start, or wait 2 days before you start. Whereas the low bleeding risk patient, you can start immediately. So this is a well-proven, accepted way of managing the DOACs perioperatively. What about a patient that comes in for urgent surgery? You can see here, you need to know which drug it is, when did the patient take the last dose, what is the patient's renal function. You can do the normal PI-PTT. If you can do a thrombin time, it's a good idea for the bigatran. And we do the drug level, so do the drug level. If you have a drug level less than 30 nanogram per milliliter, you know there's nothing on board and you can go ahead. That's the quickest way of getting an answer for emergent surgery. You can see there's the drug level, 30 nanograms. On the other hand, if you have a patient on the bigatran and the thrombin time is normal, you can also go ahead. The thrombin time is a very good indicator of the bigatran. Using things like adurisuzumab or Praxbind, these are the antidotes for DOACs. We do not have all of them in South Africa, but that's very expensive. And if it might be used, but we tend to think rather set it out a little bit. And if a patient then bleeds, you can use activated FIBA if needed, or even better, you can use factor 9 concentrate, hemosolvex, not hemosolvate. What about antiplatelet drugs? So that what we've spoken now on is taking a patient on anticoagulating to theatre. What about antiplatelet drugs? If a patient is on an antiplatelet drug, I'm not going to go through them again. Yeah, it's the same question. You need to know, why is the patient taking the drug? And it's mostly for 3 reasons. One, it's primary prophylaxis. A patient feels that it's safer. He's read in some magazine that it decreases your risk for colon cancer, which is true. Or they think they have a strong family of cardiac disease, they're going to take it. So that's primary prophylaxis. Secondary prophylaxis is the patient's already had a previous arterial event, or the patient's got diabetes, etc. And that's why they're on antiplatelet drug. Those patients got a higher risk. And the highest risk is a patient where they really need an antiplatelet drug. For example, a stent. Now, the problem with stents, people think a stent is a stent is a stent. It's not true. Certain stents, every stent, what happens with a stent, they put the stent into the artery and you re-endothelialize that stent. In other words, the endothelial cells very quickly grows over that stent. And once they've grown over that stent, you've got a patent artery and a safe artery. But some of these stents have got drug-eluting stents. In other words, they elute a drug that's toxic to the endothelial cells. It takes much longer for the endothelial cell to re-endothelialize that stent. So drug-eluting stents need a long period of antiplatelet drugs, whereas the bare metal stents, they clot much easier intraoperatively, but the bare metal stents will have a shorter period. So, and then the second thing is you need to know, how does the rest, if somebody has a stent and it's a single lesion, it's okay, but many patients with a stent does have underlying atherosclerotic burden, in other words, around the stent. So the only person that can really tell you if you can stop a platelet drug on a stent prior to surgery is the cardiologist that put the stent in. Yesterday I had a patient, somebody phoned me, and he's really a cardiologist. He's got a patient with a recent stent on with atrial fibrillation on triple therapy. In other words, the patient is on antiplatelet drug and anticoagulant, actually 2 antiplatelet drugs, aspirin, dispirin, and Eliquis, Zyquis. Patients are really on Zyquis. So it's a Pixiban plus aspirin plus Plavix. And the patients develop major gastrointestinal bleeding. So he said to me, what can you do? I said, it's a problem. Can you stop the antiplatelet drug? He said, I can stop the anticoagulant, but I can't stop the antiplatelet drug because of the stent. Because the AF, the patient's got is not a high Chatsworth score. And then what they did yesterday, they went in and they tied off that artery. So local measures, then it's a good idea. But in other words, these patients are really a problem. A stent is a problem, be careful. Again, you need to know what type of surgery the patient has, and it's exactly the same steps. The first step is, what is the patient's thrombotic risk? In other words, is it primary, secondary, or is it a stent? What type of surgery? Again, the same types of surgery. Do you need to interrupt the antiplatelet therapy? And do you need to bridge? But you can't bridge with a lumped white heparin. We can't really bridge in South Africa, because we don't have kangaroo available. A practical way of looking at it is if a patient is on an antiplatelet drug and he needs to go to theatre, you need to decide, is it elective on the blue side or is it emergency on the green side? If it's elective, you can see how long you need to stop these drugs prior to surgery. Ticlet, Brilinta, Plavix, aspirin, you need to stop the different periods that you need to stop it because you have time. Bridging, you can bridge, but we can't bridge, unfortunately. Point of care testing, we know that you can do point of care testing, the microplate, etc. It's not really always available. But on the other hand, if it's emergency, you've got a problem. A patient coming in that's on Plavix that needs to go to theatre and he's taken his Plavix 2 hours ago and he's now got a hip fracture, you can give him all the platelets available from blood bank. That Plavix will just inhibit them. So you need to wait 6 hours post Plavix to start giving him platelets if you need to. So it's just a practical point to remember. With Ticlet, it's even longer. We don't know how many you need to do and Ticlet, but we don't use a lot of Ticlet because of the TTP risk. Okay, so practical again. If you look at what is the bleeding risk high and the low thrombotic risk, stop. If the bleeding risk is low, the thrombotic risk is low, we're not worried about bleeding, you continue. Low bleeding risk, high thrombotic risk, rather continue. It becomes more difficult with Plavix and Brilinta, and especially with dual antiplatelet therapy. Dual antiplatelet therapy, at least we need to keep one of these going in these patients. But I'll show you now. So this is really what we need. I told you that Brilinta, stop longer beforehand. Ticlet, you can stop shorter, and then Plavix 5 days at least. And and then you do the surgery and you can start again. And if you have kangaroo, you can breach them, but we don't have it, so we can't breach them. I'm not going to talk about that or that. So bottom line is, what about drugs? Let's quickly have a look at the drugs. We've got garlic, ginkgo, and ginseng. And you can see here, they're active against platelets most of the time. You can see garlic, 7 days, it's better to stop 7 days beforehand. Ginkgo biloba, 36 hours beforehand. Ginseng, 24 hours. So 3 Gs that patients should know about prior to surgery. What about LPs? Doing an LP in a patient? Discontinuing the medicine if they've got a normal renal function. You can see aspirin, you don't need to, but Plavix, 7 days prior to surgery, and then you can, when can you give your next day dose? And remember, you need at least a platelet count of 50 plus to 70. Only look at the drugs. And if the platelet count is lower, you also need to consider that the patient with a low platelet count and aspirin, you can't just continue. We've seen that. And you can see here, it's really easy to read off. You can read this off and you can see how long you need to avoid. With the one thing to remember with Arixtra, it's got a 36-hour effect. So avoid doing LPs on Arixtra. What about epidurals? You can see here how long before you put the catheter in other stuff, like we've just said now. Whilst the catheter is in place, can you give the anticoagulant or not? And before you remove it, how long should the patient be without an anticoagulant? And how long after removal of the epidural must you wait before the anticoagulant? So it's really easy. I can read it all, but then anybody can read it. It's available from the New South Wales government website. Just need to quickly tell you, just remember, you can't use DOACs while a patient is having epidurals. They can't be given DOACs while that epidural is in place. It's important to remember. And then you wait 36 hours. You remember we said 24 hours, 48 hours. Yeah, with neural axle procedures, we should be a little bit careful with our DOACs. What about antiplatelet drugs and epidurals? You can see here you can never do epidural if you can't give ticlet whilst the epidural is in place. Okay, so what about blocks? Blocks, you get 2 types of blocks. You get a deep nerve blocks and superficial nerve blocks. You remember I told you about the retrobulbar anesthetic for cataract surgery, putting these patients into a higher risk. And you can see here this nerve blocks. If it's a deep nerve block, you need to be careful, and you have again the period, same type of thing, period that the patient should be without anticoagulation, and then how long you should start again. The superficial nerve blocks, it's fine. You can give and you can see which ones are the superficial ones. Occipital, peribulbar, but not retrobulbar. I'm a little bit worried about that. I tend to put it on that side to make sure, because if you get bleeding there, you're in trouble. Guidelines again for the anesthetic people there. So the summary is the following. We have these guidelines. We need to know what is the thrombotic risk. In other words, why is a patient on anticoagulation? Second thing is, what is the bleeding risk in a patient? What is the bleeding risk of surgery? And what is the thrombotic risk of the procedure? The important things is the first one and the third one. And if you now really think, good heavens, what a long-winded lot of nonsense. It's much easier if you just go to the website thrombosis.canada.ca and you click on it and you say clinical tool, and it opens up. And the clinical tool, you click on peri-operative anticoagulation management, and this opens up and it asks you, is it elective surgery? Is it emergency surgery? Is it urgent surgery? And you click it, and it asks you a few questions, and it tells you exactly what to do. So you needn't have listened to me. You can just have the website. It gives you even this. And another one that you can have on your phone is the MAPPP that you can download, and it's very easy. It starts off by telling you which drug is the patient on, and you click on it, and then it asks you what is the bleeding risk. And if you don't know, you click on more information, and you pick whatever the patient is having, and it goes through the same thing, bleeding risk, thrombotic risk, and then it tells you, you know what, this patient is on warfarin, this is the risk, you need to bridge it, and this is how we suggest you bridge it. So you don't need to know anything these days, it seems. Everything is available on your phone. That's it.
Thank you so much. You know, this is like, yeah, you're truly a legend, because these are questions that probably lingering most of the professional fee. And I mean, professional mind. I think you have spoken like a physician. You should be next to the patient during the ward rounds, not on the screen. So
that's why that you know what, I did clinical hematology and I realized how hard work it is.
but thank you so much. You know what, like a few months ago we had a patient that actually went for back surgery, and he took an aspirin. I think it was a day prior to surgery. And then of course post-surgery he had really massive bleed, you know, bleed from HPO 11 to HPO 5. So we required to now to keep the patient a bit longer in ICU, transfusion, another 3 days, the bleeding actually stopped. Now, in the case of aspirin, do we have...
In the case of aspirin?
An antidote immediately.
You know, yes. you can give platelets. If a patient is bleeding, you know, what we know, you can give vasopressin, but cyclocapron can work. Your problem with a platelet dysfunction is that you need new platelets. Platelets cannot redeem themselves. Like kamikaze pilots, you know what, they haven't got a nucleus to redeem themselves. So the only way is to give more platelets or other platelets to the patient. And you can if while you wait for platelets, you can give cyclocapron, because cyclocapron will increase or will help with that platelet interaction with von Willebrand factor. But mostly with a platelet type of bleeding, you need to give new platelets, which is not always available, unfortunately, and has got risks. You know what, people underestimate the risk of a platelet transfusion. Platelets are really a bag of platelets are really from different patients. You do have bags with dedicated, but we use those bags for the oncology patients where it's a one donor bag of platelets. But most bags of platelets that we have have different donors, and you get exposed to different antigens from different patients. So a bag of platelets is not something that you can just give because you think it's necessary. But that's part of patient blood management.
But I think the most important, obviously, is saying that you don't actually need to look at the platelets level. I think having the history of the aspirin taken, then you need to actually cyclocapron and probably platelets, depending on how life-threatening is the bleeding.
The big thing to remember about platelets, you remember, you know, if your platelets are low, you're going to bleed. But it's not only the platelet number, it's also the platelet function. And the important thing is you will see that we have under the platelet count, we have a little thing called IPF or PDF, immature platelet fraction, or platelet PW. Michelle, what do we call it? It's the size. It's an indication of the size of platelets. It's an immature platelet fraction. So if you have a low platelet count, you need to know whether this low platelet count is because platelets are being used up or are they not being produced. A patient with a platelet count of 5 in ITP, they don't bleed easily, you know that. A patient with a platelet count of 30 in oncology will bleed because it's dysfunctional platelets. So if a bone marrow actively making new platelets, these platelets are young and large. So if you have a full blood count, and the immature platelet fraction is high, and the platelet count is on the lowish side, you feel lots safer. If the immature platelet fraction is low and the platelet count is low, that patient will bleed because those are old You know, old men don't work as hard as young men. So old platelets only last for 5 to 7 days. After 5 days, those platelets are a little bit tired. And especially now they're even small and decrepit and only a few of them. So bottom line is, if you see a low platelet count, you need to look at platelet count. You need to look at platelet function. But if you look at platelet count, don't only look at the count, look at the IPF. Look at the immature platelet fraction, because that tells you a lot whether that platelet count. There's this crazy tendency to keep a platelet count above 50 in ITPs. It's crazy. If you have a platelet count of 30 in ITP, you're happy. You don't need to have very high platelet counts in ITP. You know, it's been said that you need a platelet count of 8 to keep your hemostatic function going. In other words, 8 platelets can do the job if they're young and active. It's like working in a mine. 8 young guys can work in a mine. You can take 50 old men, they won't do a thing. It's the same principle.
Unless they're like me and you, eh?
Yeah, we'll have to.
Thank you. Any other burning question? We have one last question.
I've got one question, Piet. I just want to know, if you bridge a patient with something like Clexane or Noxfibra, is there any point in doing factor 10A level beforehand or even afterwards?
You know what? The only time that I do that is when I think these days people are crazy. They want to sue you for everything. I'll quickly tell you a story. We've got 1 minute. Many years ago, I think all the people here except the old men were still in primary school. A patient came to me. She said, I'm going to have ankle surgery, but I need to see you. I said, why do you need to see me? She said, yeah, because I had a previous deep vein thrombosis. I said, well, you know what happened? She started telling me she had a pulmonary embolism, she had a stroke. I said, so what's wrong? She said, no, I've got antiphospholipid syndrome. I was dead scared. I then said to her, so tell me, why were you from Joburg? Why are you here? She said, no, my husband is the brother of one of the orthopods in Pretoria. I said, oh, really? What does he do? She says, no, he does medical legal cases. And then I got more worried. And I spoke to the orthopod that did the ankle surgery. And I said, you know, this is a very high risk. I think you should just send it to your opposition. He said, no, he wants to do it. And he's a very nice guy. He's retired now. He did the surgery. I said, you know what, let us do the following. Let us stop her warfarin. We continue her aspirin. We give her BD Clexane. We do anti-10s. We did that. And we saw that the anti-10 is 0.8, I can't remember exactly, but it was not bad. She then, 24 hours prior to surgery, at ankle surgery, the evening I went there after surgery. I did at that stage, whilst in Pretoria, I did go to the hospitals. And I had a look at her, and he came out of theatre. I said to him, how did it go? He said, perfect, man, not a drop of blood. And I was ice cold. I said, you know, I wanted a drop of blood. So he then said, no, it was perfect. I said, no, let's start the lung-grade wide open. He said, no, we're not going to start. We'll start tomorrow. I said, no, we start today. He said, no, we start tomorrow. I said, we start today. He said, there's arthrodesis, something will happen. I said, no, we start now. We had a fight. He eventually said, okay, we'll start at 10. We started at 10. 5 o'clock the next morning, the sister from the ward phoned me. She said, you must come, the patient can't speak. I got there, she had a TIA. He came in. Fortunately, another physician came in. He resuscitated me. Her husband came in. I explained to him, I said, we did what we could. We admitted her in ICU. She was fine. Surgery was fine. She was back. We put her back. And when she was still getting Clexane the whole period. She developed a pulmonary embolism in ICU. And I was so happy with my anti-10s. And ever since then, I do an anti-10 in the high-risk patient. I just need to know I'm safe. I know that money spent, it makes me sleep better if the devil wakes me up at 3 o'clock in the morning.
Prof, one last question. You're always going to be professor to me. I apologize, but I'll always call you Professor. I think it's just on my tongue. I can't explain. Prof, the big dilemma coming about patients that are obese with a BMI of more than 35, or those with a weight of more than 120. And in the past, those patients were condemned to get warfarin if they got pulmonary embolism or thrombosis. But now, I mean, we don't have evidence. The pharmaceutical companies have not changed their information to see that this patient can get it. Can I use now the fact that we got tools, we got anti-infected 10 for Taroto Afexiban? Can I able to titrate my anti-infected 10 on those obese patients without actually deprive them of this novel medication?
No, you don't titrate, you just do a level. So it's been shown above 130. We're a little bit worried about the once a day. The two, I can send you the articles. The latest say that you can use it. And rivaroxaban, it's once a day. And we think maybe a BD dose in these patients will be better. That's why we tend to say rather use a Pixiban and do a level. And you know, you can do a trough and a peak level, and you know, especially a peak level, just before he takes his new medication, you know you're fine. It's been shown that you can use in the obese patient. Where they looked at this is in the patients with gastric bypass surgery. I'll send you the article today. I'll send it to Michelle, and Michelle can send it to all of you.
Thank you. Thank you. We really always appreciate you talking to us. And I think, yes, we're going to share the podcast with Wits University and University of Pretoria, because I think we have issue with the communication, but I think most people can learn from it and been a challenging cases. And I think, as I say, look in South Africa, there are a lot of people actually who succumb for bleeding for surgery because of these problems. And I just wish people must start learning and try to get this kind of wisdom from above. Thank you so much. We appreciate it. And I hope one day you can come live to us here in the office so that we can meet you personally.
Have a wonderful day.
Thank you.